Hello, I'm Dr. Clay Goodman. I'll be narrating this PowerPoint presentation for Chapter 375, Neuropathology of Traumatic Brain Injury in Yeomans and Wins Neurological Surgery. Before we begin, it's important to note that the amount of damage done during traumatic brain injury depends on the amount of kinetic energy that is delivered to the tissue at the time of injury. However, that sets into motion a series of events that may evolve over a period of minutes to hours to days, weeks, and possibly even years. We will consider some of the classical neuropathological injuries seen. Now, experienced neurosurgeons will recognize that scalp lacerations and skull fractures can certainly occur. The lacerations may be very impressive and may distract attention away from more serious injuries. Skull fractures reflect the skull doing what it's supposed to do. It's like the shell of an egg. It fractures in order to dissipate that critical kinetic energy we mentioned earlier. If there's a skull fracture and then damage to the underlying vascular structures, we see injuries like this. An epidural hematoma, frequently resulting from a fracture in the skull lacerating the middle meningeal artery. The blood accumulates between the bone and dura under arterial pressure. Because the dura is to skull what periosteum is to other bones, these epidural hematomas will respect coronal sutures. They're also striking in that they can progress quite rapidly, but they may be separated from the time of injury by a lucid interval. In contrast, the subdural hematoma does not respect the coronal suture lines. It's not really subdural. It's actually a hemorrhage within the dura. There is a layer of the dura called the inner border cell layer, which is quite weak with relatively few tight junctions, and blood accumulates in this region. The blood accumulates more slowly than is seen in the epidural hematoma and triggers the formation of granulation tissue, that is, proliferation of small vessels, which subsequently may themselves bleed. Now, the hematoma and the granulation tissue may be walled off by a layer of fibroblasts, which form the layers of the subdural hematoma. So here's a compare and contrast. An epidural hematoma will respect coronal suture lines, whereas the subdural hematoma will not. Now, if we consider injuries that involve the brain itself, we see contusions, which are really basically brain bruises. These are hemorrhages on the surface of the brain. It's important to note that these tend to occur on the crests of gyri, whereas hypoxic ischemic injuries will be more severe in the depths of the sulci. They also tend to occur in certain regions. The inferior aspects of the frontal and the temporal tips often collide with the irregular bony contours of the skull, and these are sometimes called gliding contusions. Here's an example of some cerebral contusions, both acute and chronic. Here's a lethal acute contusions. You see a lot of hemorrhage in the frontal region, some in the temporal tip on this side and some on this side. A lot of brain swelling, and this was was lethal fairly soon after injury. Now, if the patient survives the injury, then these areas of hemorrhage will be cleared out by macrophages, leaving some hemosiderin, and so you'll have this brownish discoloration where the contusion was. Also note the olfactory nerve here, and how the olfactory bulbs have been destroyed. Anosmia is actually the most common cranial neuropathy following closed head injury. Now, it's not always just gliding contusions that are relevant, however. Where the energy is delivered is also important. And the contusion, that if a contusion occurs at the site of impact, that's a coup injury. It's classically associated with a stationary head which is struck. So a patient is struck by a falling object or struck with a pool cue or baseball bat. So the head is struck by an object in motion. So if the right frontal region is struck, then, and the head is stationary, then the contusion may be large in this area. Now, 180 degrees away from the contusion are contra-coup contusions. So if you get a right frontal impact, you might get a left parietal occipital contra-coup injury. Now, if the head is in motion and decelerates, as in a fall or motor vehicle accidents, then the contra-coup injury may be larger. And so this can sometimes be helpful in forensic pathology. Now, if you go beyond contusions to through and through injuries, in the United States, these most commonly are the result of gunshot wounds. During the passage of the bullet, energy is transferred from the bullet to the tissues. In the millisecond or so it takes the bullet to pass through the brain, kinetic energy is transferred, and there's a large cavity of high pressure that surrounds the path of the bullet. You can see illustrations of this sometimes if gelatin blocks are penetrated by a bullet, and the shock waves of this bullet can do severe damage that's well beyond the path of the gunshot wound. The faster the bullet, the more intense and broader the shock wave, because the amount of kinetic energy that the bullet brings to the transaction determines the amount of kinetic energy that can be transferred to the brain. Now, if you reach back to college physics, you will recall that the kinetic energy of a moving object is 1/2 times mass times velocity squared. And so the kinetic energy of a bullet goes up with the square of velocity and only linearly with a slope of 0.5 with the mass. Now, in civilian firearms, mass is often used to increase the kinetic energy, whereas in military weaponry, high velocity, smaller mass projectiles are used. Now, we noticed when we looked at the brain that you really couldn't tell the direction of the bullet by looking at the gunshot wound. However, if you look at the skull, you can discern the trajectory. So when a bullet enters, penetrates the skull, there's a small entry hole and then a larger defect on the inner table of the skull. If the bullet possesses a lot of kinetic energy, as we showed in that picture of the brain with gunshot wound, it may actually go out the other side of the skull, and you'll have a small inner table defect and a larger outer table defect. And this tells you the direction of the bullet. And this can be forensically important as well. Now, sometimes a person will not have an epidural or a subdural or contusion or a penetrating brain injury, and yet, from the time of injury, they'll be unconscious. And that's often due to traumatic axonal injury, which is also sometimes called diffuse axonal injury. And what you see here is what are called axonal retraction balls. These are where the axon has literally been transected. Now, this can be a very patchy process. And we know that the axonal injury occurs at the time of the trauma, but there is evolution of the axonal changes to eventually result in these axonal retraction balls. The reason for mentioning this is that traumatic axonal injury is a process, not an event. So we imagine a normal axon. There's closed head injury. This area of the axon is damaged, and over a period of hours, axonal swellings will occur at the point of axonal damage, eventually, potentially, leading to axonal separation with axonal retraction balls. The fact that this process takes hours to occur gives us potential therapeutic targets. Now, traumatic axonal injury can be appreciated better using immunohistochemistry, amyloid precursor protein. And here's an example of a closed head injury case with traumatic axonal injury. Here in cross-section, you can see the axonal swellings. Here you see a series of axons with axonal swellings, whereas adjacent axons may be perfectly normal. So traumatic axonal injury may indeed be a very patchy process. Now, we now recognize that milder form of axonal injury, traumatic axonal injury, occur and may be important in the long-term behavioral manifestations of closed head injury. One of the more recently recognized long-term consequences of repetitive head injury is chronic traumatic encephalopathy, also known as CTE. The patients exhibit cognitive decline. They may exhibit motor decline, often with extrapyramidal or Parkinsonism-like features. Neuropsychiatrically, they may show explosive personality and impulsivity. These are progressive clinical features which may occur years after the patient has experienced repetitive head trauma. This has been studied most closely in football players in the United States, but it has been seen in other forms of repetitive injury. And one of the interesting things about this is there's hyperphosphorylated tau inclusions, but unlike the neurodegenerative diseases like Alzheimer's disease, Pick's disease, these are in the depths of sulci initially. They may be patchy, and then over time they become more widespread. There's no compact neuritic plaques such as are seen in Alzheimer's disease, although one may see diffuse plaques. More and more is being learned about this. We're also studying how it can be that you can start with disease, let's say, in the right frontal region, and then it spreads possibly through a templating mechanism to other parts of the brain. So circuits that are connected may be conduits for spread of this abnormally positioned hyperphosphorylated tau. So CTE is a disorder in which trauma meets neurodegeneration. And this has also been highlighted by a rare form of CTE in which there's also associated motor neuron disease. Now, we do recognize that in the acute phases following injury, there are a lot of secondary mechanisms for continued damage to the tissues. Reduced blood flow is common. Release of excitatory amino acids, free radical generations, disturbances of nitric oxide, which are involved both in the immune response to damage, but also in blood flow regulation. Mitochondrial dysfunction is common. The tissues are often acidotic. And so we see a combination of acute events and then cerebral acute phase reactions, which are basically immune system, microglial, and also systemic monocytes participating in an inflammatory response. So as I mentioned early, neurotrauma is a process, not an event. The acute injury occurs and sets into motion secondary injury mechanisms. And that leads to some trends in neurotraumatology directed at detection and reduction of secondary injury. We're seeing more online neurometabolic monitoring, complementing physiological monitoring in the neuro ICU. There are strategies that are under development or have been under trial to reduce excitotoxic injury, to augment nitric oxide production early, to increase cerebral blood flow. Later, when the nitric oxide is participating in the inflammatory response, it may be important to downregulate it and reduce the inflammatory component. As we noticed, traumatic axonal injury evolves over a period of hours, and so there may be some therapeutic targets in this domain. And increasingly, the gene expression in the injured tissue is being studied for targets, and stem cell driven repopulation of damaged cerebral tissue is an exciting frontier. So that's a brief overview of the neuropathology of head injury. It does study both tissue level responses and their evolution over time, and helps provide us with numerous potential targets.